we'll dive into some product. But start with some intros. Like I said, my name is Patrick. I have Jane with me as well. She's our product manager for our registry tools. And then just since we've got so many people on the call from your guys' side, if we want to just go rapid fire, maybe Michelle, you start, and we'll kind of go down the line, and then which hospital you're with, or which part of the region, and then what your role is would be awesome.
Thanks, Patrick. I really appreciate you guys being here today. I'm Michelle Dahl, and regional trauma manager or data manager for Tri-State Trauma Coalition and the Health Collaborative. I have no idea whose camera or whose microphone is working next. So whoever wants to jump in, that would be great.
Tanya Kessler from Cincinnati Children's. I'm a trauma registrar.
Nicole Billiter from Atrium Medical Center. I'm a trauma registrar.
Alex, I'm calling you.
I'm Alex Carpenter. I'm the system director for trauma and burn at UC Health, covering UCMC and Westchester Hospital.
Sherry. Heather. This is why not everyone's microphones always work.
It's all good.
Jane.
This is Jane Koenig. I am product manager here at ImageTrend. My background is nursing, and I worked in inpatient quality and also outpatient for HEDIS measures before coming to ImageTrend.
Jane.
Jessica.
Hi, this is Jessica Johnson, and I'm from Cincinnati Children's, and I'm a trauma registrar.
Thank you. Brian.
Hi, I'm Brian Kegley with the Health Collaborative. I'm a nurse here at the Health Collaborative. I'm the Senior Manager of Analytics and Business Intelligence.
Awesome.
Jill.
Hi, I'm Jill Keithy. I am also a registrar at Cincinnati Children's.
Matt.
Hi, I'm Matt. I'm the trauma program manager at Westchester Hospital.
Katie.
Katie Stegman. I am the trauma program manager at the President Hospital.
And Susan.
Susan Wright, trauma data analyst at Kettering Health Main Campus, and we cover Fort Hamilton.
Terrific.
And then Kara just signed in. She's with Tri-Health and the trauma registrar there.
Yeah, thanks everybody. First off, too, we like to keep these fairly laid back. So if you do have questions throughout our call today, please ask. We'll try to fill in some time with pause breaks to make sure that everybody's caught up with what we're showing. But if anything is scratching at your brain and you want to ask, please interrupt, and we'll take those as they come in. So now that we got some intros out of the way, I want to talk to you about just a little bit about who ImageTrend is and what our solutions offer today. And then we'll dive into some product with Jane, and then leave maybe 10 minutes or so towards the end to go through questions and talk about kind of what happens next. So again, appreciate your time. We'll jump right in here. So for those who haven't interacted or know about ImageTrend, we've been in business for 26 years. One of the leaders in hospital patient registries nationwide. We do have, as you can see on the screen here, 21 statewide systems today that are in place that are acting as both a repository to collect data, but also provide access for hospitals to document their trauma registry incidents directly into those systems today. We're over 1 million records collected in the last year. And then kind of a breakdown, we do have over 700 hospitals directly entering into our registry, and then over 3,000 active users today. As far as our Ohio footprint, it's growing pretty fast. From the hospital-based systems, we're in with ProMedica, Metro, Nationwide Children's. We're doing some really cool integrations with our pre-hospital into Epic at OSU. And then we just this past week had brought on Columbus Division of Fire for their pre-hospital EMS and fire documentation tools. So more likely than not, if you have any friends in the fire and EMS service, they're probably using us today, if not in process of switching over. So I want to keep that really brief and quick. Really want to dig into some of the things that we want to dive in with you today from the notes that Michelle and I had from our call last week. The big things are obviously walking through the life cycle of an incident. So we'll show the process of getting information documented into the registry, and then on the back end, there's some really cool capabilities on the reporting front, where you're going to be able to pull out stats and also get your data up to the state and make that easy for you. So, like I said, if you have questions throughout today, please interrupt. But I'm going to hand it over to Jane, and we'll share some screens and dive into some of our solutions today. So, Jane, I'll let you take it away.
All right, thanks, Patrick. Are you able to see my desktop with ImageTrend on
Yes.
it? Okay, all right, great. So this is the kind of the home base or the starting point. We call it the dashboard. On this dashboard, it is tailored to each individual. You can put various widgets on it. Any report that you have access to in our report writer, you can add that to that, and you will see, like over here, we have a bar graph, we have a pie chart, another bar graph. So, and down here is a report where you can actually click on an incident. This is the incident. You can click on it. It'll actually launch that incident for you, so you don't have to look it up. This one happens to be incomplete charts, and we'll talk about how you really shouldn't have anybody on your incomplete charts with using validation rules. But also on here, we have the recently created incidents, which is something a trauma registrar would use, recently viewed. Admits to review. This admits to review is there for if you have an HL7 or an integration with your EHR. In that integration with the EHR, it's sending over the ADT message, and it says, hey, you should review it to see if this is really a trauma case. If it is a trauma case, then you convert it into a trauma incident. We use incidents as kind of a carryover from the EMS world. There are other widgets on here. If you are a PI nurse, we have a PI open audits and a complications open audit. You can put notifications out here. ImageTrend also puts out notifications on here. And again, some more reports down here where you can see it's just some tabulations that are being done. You can put sticky notes out here. You can put messages up here across the system. You can ignore this one because on August 13th, they are not going to take the system down this morning until we are done. But they put messages out here if there's some kind of maintenance that has to happen during the time. Across the top here, incidents. Incidents is where you can go and search for incidents. We have multiple ways of searching for an incident. You don't even have to go to this incidents to search. We have what we call a quick search here. In this quick search, you can put in an MRN number. You can put in their first name, their last name, a registry number. And if I put in any one of those, it'll find that person, and then I can go about it. I don't have to come to the incident search. But the incident search is there, and there's many ways that you can search for somebody. We have an advanced search where we have more fields that you can put in here. If you're looking for something very specific, particularly if you get a common last name, you might want to come in here and put in some specifics to do the search on. Report Writer, we're going to talk about Report Writer in a little while. It's a very powerful tool. The Data Exchange, we'll talk about that also. Data Exchange is where you would come to run an export, to export your data to send up to the state, or to export to send to NTDB. Under Community is what we call our user voice. User voice is a great tool in my eyes. User voice is where you can put in some ideas, an idea, submit it. Other people that use ImageTrend Patient Registry can see that idea and they can vote on it to say, hey, this is a great idea. As a product manager, we go through the user voice and say, hey, that's a great idea. Let's put it into action and let's get it coded. And when we see that a user voice has lots of votes, that means it's a pretty popular item. The help here is a powerful tool also. It has all the release notes in there going back, I think, 6 years, 7 years. And then it also has some how-to videos in there that you can walk through step by step with the video. We have monthly user group calls that are well attended and pretty verbose most of the time, where people are sharing, hey, I learned how to do this, or I got this problem going on, or even just 1 month we talked about how people staff for their trauma registers and if they use any staffing agencies. And so those are recorded and also put into our university. Over here under tools, you will see staff, users, and setup. Those are for hospital administrators. So as you as a hospital administrator, you would come in here and you would set up your staff. So staff are those who provide care in your organization, and users are those who will actually be documenting within the registry. Under setup, there are some areas where you can set up, for example, the hospital can set up user-defined questions, where you can put a question out there, and I'll show you some of those user-defined questions. You create your own question for the hospital. No other hospital has to use it. You probably want to, if you're doing some research, is a typical area that people do put out questions in. But again, those are specific to your hospital and fully reportable. The other thing under setup that you can do as a hospital is you can say, hey, these are my favorite codes, favorite ICD-10 codes, favorite procedure codes. And then there's also, you can create a correspondence. A correspondence is really kind of like doing a mail merge, where you set up a template and then you can take that template and send out letters to a referring hospital. You can send a letter to an attending or admitting or whomever else you want to send a letter to, and it merges in data from the registry. And those you can set up by hospital. You can define other areas under here, like set up your own PI audits. PI performance improvement audits really are hospital specific, so you can define your own performance improvement audits at the hospital level. I don't know if you as a state have any state performance improvement audits that the state is looking for you to do.
No, we don't. We
Okay.
have a PI work group, but it doesn't have any formal audits that are being looked at currently.
Okay, all right. Some states do, and we have that set up where if you did, you can define them at the state level. But as a hospital, you can define your own hospital-specific performance improvement audits. And then there's some other setup auto numbering and such under here. The other areas under admin, you will have a system admin selected within your organization who will administer. And it doesn't have to be one, it could be multiple. But this is a lot of the setup that goes on. They will define the forms that you use for trauma, or any other type of, if it's a stroke, burn, or cardiac. But they would define the forms, they would set those forms up. They're the ones who are responsible to go through the release notes each month. And as we release new functionality, they might want to turn it on and activate it. So that's what this menu is for. Up at the top here is just ImageTrend admin. That's my login. I can set some parameters for myself. If I have access to multiple hospitals, if you're a registrar, you probably have access to one hospital. But if you're at a hospital region, if you have a region, or even as a system administrator, you might have access to multiple hospitals. We have regions set up so that if you take your region and you want to put 2 or 3 hospitals in a region, it helps for reporting, makes it easy to go in and do that reporting at a region level. And you will see I have multiple regions in here, multiple hospitals. I happen to be at ImageTrend Hospital today, so that's what's showing up here. We're going to go back to the dashboard here. Again, this is kind of the starting place for most registrars. When everybody logs in, this is where they do start. But as a registrar, if I've already created somebody, I can find them here. I am going to go into an existing case, it just helps to point some things out. So we're going to play with Harold King today. So this is on the left-hand side here, these are our tabs. And these tabs kind of emulate in the hospital EHRs. Many of those EHRs from a hospital have the left side navigation. So everything is kind of color driven and we have visual indicators. So you'll see on here, demographics is in yellow. It means that's the tab that I'm on. Anything in green means I've got everything done on that tab. If it's red, there's something that's outstanding that I need to do yet. So on here, we also have some other indicators within the tab that says, hey, middle initial is required. You should enter that. Race is required. So they can enter that. The little red, it almost looks like a stop sign with a line through it. This is to record a not value. So in those instances where a date and time, but you don't really know the time, you might know the date and you don't know the time. Well, we don't want you to lie about the time and make something up. So you can record a not value here, in which the not value just says, hey, it wasn't available, it's not recorded, it's not there's no reporting, it's unknown. So that's how we can handle the times. Also for postal codes, you can do that for postal codes too. If you don't want somebody to actually be able to use the not value, you would inactivate that. As a system administrator, they would do that. Did somebody have a question? Okay, I'm sorry, I thought I heard somebody. So there's a lot of visual indicators on here. Up at the top here, you'll see it says patient race is required, middle initial is required. So these are called validation rules. So as the user goes through here, the first time they open up an incident, they won't see that because we drive them crazy. Because on this page, we could have multiple validation rules that are checking, like, did you have first name, last name? Because you could see the little asterisk there. Did you put in the postal code? Did you put in the city, state, and county? Did you answer any other questions on here? So we don't show those until after they have submitted this page. Otherwise, we would drive them crazy with all these questions sitting up here. So those are called validation rules. The validation rules, we distribute validation rules, but we expect that you would inactivate some and that you would create your own validation rule. Again, if your state has some requirements that you want to make sure that if there's a state defined question on your form that they do answer, you'd write a validation rule for that. Again, we provide validation rules also, and you might want to inactivate those. I'm just going to scroll down here. Down here, you will see under demographics, register notes, facility questions, research. These are set up facility defined questions. Now, nothing against salespeople and Patrick, but salespeople can ask some kind of funny questions just to use for the demos. One of them that's not on here is what color socks, because I guess the socks you had on when you have an accident is important information, but obviously we have some Texas Ranger fans in our sales area. When you set up your facility defined questions, you can make them a radio button like down here. These happen to be text fields. You can fill in a text field, or you can have a drop down. You can have a date, you can have a date time, you can have just time. So there's a lot of ways that you can configure the facility defined questions. And again, however you configure that in Report Writer, you can get that report out. And I will show you when we talk about Report Writer. I have a report on color of socks set up. And so anything that you set up as a facility defined question is fully reportable in Report Writer. I'm not going to go through every one of these tabs. I will just talk about them in general. We'll go to pre-hospital first. So this is like your EMS information. And under the EMS information, you can pull in EMS data from your local agencies. So for example, if you say, hey, I have this EMS agency that I'm affiliated with, and you could go out there and query with them and set up so that you could pull in the EMS record. When we pull in that EMS record, you will see down here where we pull in that EMS record, there wasn't much in this record that was documented. We pull in the vital signs if they're documented in the EMS record, which hopefully they are. Again, this is our sales test data. So you pull in the EMS. I clicked a little bit too soon there. The EMS information. The other thing is when we pull in the EMS record, we also attach a PDF, and I'm going to scroll over. I made my screen a little bigger so you can see the attachments here that we pull in. So here's the EMS record. We pull in that PDF as we pull in an EMS record from an agency. The triage criteria 3 and 4 and 1 and 2 is from previous NEMSIS. The yellow and red criteria is the current NEMSIS 3.5. We do bring in the UUID from an NEMSIS 3.5. The beauty of that is that when we bring in that UUID and store it in the registry, not only do we report it to NTDB, but it makes for reporting across your EMS and your hospital to look at trauma cases across both pre-hospital and hospital when you're doing some research. So that's really the beauty of pulling in the UUID. But we do bring in EMS records when we set you up. We ask you what agencies you work with. And if it's that agency is on ImageTrend, we can easily bring in that EMS record. If the agency is not on ImageTrend, what we have to do is you'd have to import that NEMSIS record. So you'd have to talk to that agency, get the NEMSIS record and import it if you wanted to bring it in. But if they're an ImageTrend agency, which Patrick, I think, showed you, there's several agencies in the area, you can actually import that data as discrete data. Pulls in the vital signs, it pulls in any pre-hospital information, what did they do for airway treatment, any procedures, medications, pulls that in, and then it also attaches a PDF. I'm going to go down here to initial assessment, talk about a couple things on the initial assessment. And one of the things I want to show you is if you have fairly young or new registrars, we have the capability where you can put in some definitions. So for example, here on Glasgow Eye, I can put in a definition here and say, this is the first recorded Glasgow coma eye score. Here's the data hierarchy. So, you know, in NTDB, they do define the data hierarchy. You can add that here, or you can actually tailor it to say, if in your EHR, if you're all kind of on the same EHR, where to look for it in the EHR. Like you go to the ED, wherever. So you could put that information here. It really becomes helpful to your young registrars to have that information handy there. We do several calculations. The Glasgow coma score is one thing that we do calculate. I'll show you a couple other calculations that we do as we go. We're going to go down to diagnosis. I'm going to spend a little bit of time talking about diagnosis. So for the diagnosis, we keep current with all the ICD-10. ICD-10 is usually updated twice a year. So whenever there's an update to ICD-10, we distribute those updates out. We are AIS 2015 ready to go. So you will see here it says AIS 2015 code. Now, if I hadn't flipped the switch, and I could be still at 208 at the version of 2005, but in our diagnosis, we have several ways that you can search for diagnosis. I can put in contusion, and the system's going to go out there and it'll find contusion for me. If I wanted to put in a code like S00.03XA, I could, so I can either put in some text or I can search by a code. The other way, the third way that we have of looking up diagnosis is what we call the lookup. This is where we find we get a lot of feedback from the younger registrars, or I shouldn't say younger, but registrars who are inexperienced. They can do a category search. This search is true for procedures and for AIS codes. So in the category search here, it brings back all the categories here, and I can come out here and I can drill down into a specific area. I'm going to say they had an injury to the neck, and I can keep drilling down until I get to the end code here. Once I select that end code, the system suggests an AIS code. This AIS code I can accept or I can change it. How we do the AIS to ICD coding, the ICD-10 to AIS codes are not a one-for-one match. Excuse me, they're not a one-for-one match. So what we do is we go out and survey our level 1, level 2 trauma centers every year, and we say, okay, what was the most commonly used code for S10.0XXA? And then we go through and we tabulate up, oh, this was the most commonly used AIS code. That's the AIS code we suggest. Now, you don't have to accept that code if you don't like that code. You can go and do a lookup for the AIS code. Again, you can also type in a code. If you know AIS codes, you can type it in. If you know just part of the name of that, you can do that. But I can come out here to NEC, and then I can drill down here into NEC and find the AIS code that I want.
Jane, we have a question.
Yes.
Does this work inversely? So if you have an AIS code, can you put that in and it suggests an ICD-10?
It does not. I know there are companies out there that do it that way. We had made the decision to go from ICD-10 to AIS codes. I think many of the vendors, everybody kind of has their own way of doing it. One of the things that we're looking at is how we could use AI to actually come up with the AIS code. AI means artificial intelligence. So we could look at not only at the diagnosis, but look at other things that have been documented so far to come up and suggest that code. That's just kind of in the works, and we're just starting to do some research on it. By the individual login, you can turn this off. Some organizations have, but they don't want like the auto suggestion, and other people really like it. So it's kind of all over the place. I would say majority of everybody uses it. They like it. And like I said, again, we look at our trauma level 1 and level 2 facilities and see what are the most commonly used code for a diagnosis. Down at the bottom here, you will notice that it's calculating the injury severity score here based on what I put in. It comes up with a score of 10. If you don't know how this gets calculated, you can click on the little question marks you'll see down here, and it gives you information about how we calculate that. The other thing over here, probability of survival, that also gets calculated, but that is not calculated right now because it's looking for some vital sign information that I have not documented, but that gets calculated also. And then we have the NIS also. So those are calculations, additional calculations that we're also doing as you go through here. Talk a little bit about procedures. On the procedures, sometimes you have a patient that comes in and they go down to radiology and they might have 30 procedures done at one time, or maybe 10. Procedures is much like diagnosis. I can just type in part of a definition. I can either type in some text, or I can actually type in the codes. I'm always amazed by registrars who knows these codes off the top of their head. I certainly usually have to go use a lookup over here where I can go down by the body parts or what type of coding system it was. So if I pick that this was a CT scan, and then based on what I say for the location, if I say the location was done in ICU or radiology, I get different questions. So for example, when I say it was done in radiology, it brings up a certain set of questions. I can put in my date performed here. Now this person happened to come in February of 23, but I can say it was done in March and the time. And then I can go ahead and say who the requesting staff was, who did the actual reporting on it, and then what time did they arrive at down there? And I fill in the times here. And then when I'm done filling in this one, I can say add another. What add another does is like copying all this information, but I'm going to put it onto a new procedure code. The reason why we did this is that for those patients, particularly when they come in and they go down to radiology, they're going to arrive down there at the same time. The date performed is going to be about usually the same. Exam arrival time would be the same. Probably the requesting staff is the same, and the reporting staff many times is the same for the radiology. And then they can just say add another. I now can come up here and quickly go in and say, okay, I did another CT scan or whatever I did. And then that information carries forward. And then I can just change those particular items. Like if I put in the exam finish time, I could change that. So I just have to change minimal data. It's a way to quickly get in a lot of procedures quickly. That is the procedures. TQIP. So TQIP, how many of you report for TQIP?
All of the trauma centers in Ohio are TQIP facilities.
Okay,
We're
okay,
all-
okay. All right. I was gonna say, if you had facilities who are on your system, that don't report to TQIP, what we find many of our customers will do is they create one form that has TQIP on it and another form that's a little bit more abbreviated if they don't want to report for TQIP or fill out those fields. That's totally up to the organization how they want to do that. But for the NTD pre-existing hospital events, I'm going to talk a little bit about this, how we've done it so that you have a quick way to document. From nursing, we always call this documenting by exception. So for example, if I come in here now, I got some of this filled out, but I could say, no, they didn't have, I want to click on no here because that's the typical, they didn't have these things. And then I just fill out the individual areas that did have them. Vice versa, if they have a lot of things that happened during the hospital, I can click on yes and then document the no things. The same is true as I come down here and I look at the pre-existing conditions. I could click on the no or the yes and it fills it in, and then I just document by exception. Okay. That's the way that we can quickly get in some data. The other way that you can get in some data is by building in some defaults. You can build a default for the questions. So as I was going through and documenting things on like the glass glaucoma, I could say it was normal or whatever. So you can build into defaults. We see many organizations who build a lot of defaults. Other people don't like it because they really think that people skim over those questions. That's an organizational decision that you will make. But that capability is there for you to use. We're going to talk a little bit about complications and PI. Because I know all the hospitals have to do that. And we'll talk a little bit about the workflow here. For the complications and PI, we have it set up so that you can run a report for everything that's out there, or you can just report on one specific area. So at the very top here, again, any section that you see on the form here, you can take it off. You can put other sections on. I just put on commonly used sections here, and that's true of any of these tabs. Questions outside of NTDB, you can decide what questions you want on there, what you don't want. But so for the PI, I can say which PI nurse came in here and did this. These medical record injury categories, this is when the auditors walk in to your organization for your verification survey, they want so many charts pulled. We're in the process of automating this so we could actually pull this information from throughout the chart. But in the meantime, what we had facilities ask is, hey, can you actually go in there and just put this out there? So as a PI nurse comes in here, she usually knows, which of these categories this particular patient falls into, and then she can just select to add these onto the selected. And then what happens is that gets generated. This patient incident summary here, this is actually generating from AI. So what it's done is it's gone out there and looked at the incident itself and pulled in this information, generates a summary. If the nurse likes this summary, she could take and just copy that and put it into the incident overview. We are working to put out here another generate button so that each time the PI nurse came here, if she has, came here like the first day or two after their admission and started the complications and the PI audit, it may have very minimal information, but over time, more information gets entered. She could regenerate this AI and then copy and put it into this incident overview. The incident overview is really just designed to be an overview of the whole incident. Again, not all of our customers use it. Most of them do. They like it to write a summary of it. So what I could do is if I really like this, I'll just take and I can just copy that and put it down below my text box. Again, the next time I come in, there might be more additional data that the system has gone out and found once I regenerate it. But that's what the incident overview is. The complications from hospital events here, you will notice it says cardiac arrest with CPR and alcohol withdrawal syndrome. Those came over from the NTDB pre-existing and hospital complications automatically. You don't have to accept them, but we bring them over. So if I want to go work on alcohol withdrawal syndrome, I can click here and it's going to bring me up some information. I don't have to fill in all these tabs. And you may not have all these questions out there. For any of the data that you care to capture here, like location, or if there is complication staff involved and you want to record that, you can. The source, what was the source of information? You can say this came from medical record and who was there a group involved. And then I can add some additional information here about that. And this is particularly about the alcohol withdrawal syndrome. Scrolling on down here, well, you will notice a hospital event note. So you will notice that first I have a note that has a primary review, and that the type of review is primary. I have a secondary review, and then I have loop closure. So when I put in a note here, I can define what type of note it was, who was at the review. This means who was attending the review meeting or who did a review on them. What's the type of review? Again, these are not everything that you could have in this dropdown. We have more items. I just kind of select the primary ones that we typically see our customers using. If it's a primary review, what was the date of the review? And then I put in my review note. And the notes here, you can put in about 2 pages of typewritten information. I'm just going to close this out. I'm not going to save it. But you can see when people come in here and they go, oh, I wonder what's going on. And what did I get done with them last? Because, you have a lot of patients that you're following. You don't always remember where everything is. So you can see here, you did a primary, secondary, and now this one would probably be closed because it's at loop closure. At the very end of the PI, we put in items that are just kind of related to it overall. Was this determination? You don't have to use all these fields. Was it disease system related procedure provider? Again, there are more options here. I just don't have them all out here. Preventability, it was unanticipated, whatever. The findings, you can say whether acceptable, whatever. The actions, did you do some counseling with somebody? Did you do some education? And then any other actions, and then the status of it. Once I get to loop closure, I probably want to close this because it's done and I'm done documenting on it. If I leave it open, it means it's going to show up on the PI open complications and PI open audit pages on the dashboard for the nurse. The same workflow goes for the performance improvement audit. We put on here so you could quickly say if there was no PI audit filters, but I have an audit filter on here. So you'll notice at the very top here, we have the hospital specific PIs where I can select those. The ones in yellow here are state ones that are defined by the state. If you don't have state, you won't see those there. The ones in orange are favorites that I've marked as favorites for the hospital. So there are different color codings here. The hospital specific ones will come to the top here. Down here, when I click on hospital specific delayed antibiotics, again, I'm coming down here and it'll say, what was the occurrence date and time? Again, I may not know the time. I don't have to complete the time. The location, any audit staff involved. What was the source group? I can fill that in. The additional information down here, I can add that in. I would probably have quite a bit written up down here as I did the research. Down here again is the review. Here I have a primary review. I just started typing in some information here. If I came back here and I didn't complete it, I could. Who was the staff in attendance at their review and what was the date of the review? And then down here we have the closing information. Again, there are more questions you could put out down here. I just picked preventability and actions to put down here again, whether it's open or closed or not. Up here for each note, you can, like for alcohol withdrawal, I can, if I just want to print out a report just for that specific area, I can. Because if I'm going into a review meeting and I want to distribute this note to the medical director or somebody in advance, I can just print that particular one. We also have the capability of printing out everything. And I'm going to go there and I'm going to just bring up that as an example. It asks me, what do I want? Do I want the overview? I want hospital events, and I want the PI audits also. And then I'm going to generate this report. And it's going to put things in chronological order. Puts the cardiac arrest. I did a secondary review, and then the alcohol withdrawal, the information there, and it keeps on going through all the notes there. And then what was the determination, anything that I put as a closing. We do not print automatically the attachments at this time, but it does show you if there were attachments with this, which I should go back here and show you that for any one of these audits, you can add an attachment to it. You can add as many attachments, a PDF, a Word document, a CSV. So you can add as many attachments as you want. We store them. The same is true on the incident itself. You can add various attachments to the incident itself, and we will store that also. I'm just going to stop here and say any questions so far, because I know complications in PI is something near and dear to many people. So I'll stop and just ask for any questions. All right. Oh,
Jane,
go ahead. Yes.
You mentioned that a lot of this is configurable. So if there was something, I guess on here and on any of the tabs, if we had something like specific, like how you had the facility to literally create your own question, is that an option on every tab, including the PI section, or is it something that's already pre-built with you that we would just have to select and utilize?
No, you can put them on any tab that you want. Okay. And I'll just go back to the demographics, because that is where I had some questions. On the demographics here, you will see where we have something called demographics, register notes, facility questions, research. Those are configurable too by you. So if you have multiple questions on a tab and you want to group them together, you can do that also. And you define what that's called. You define the question. It doesn't matter which tab. You can put them any tab you want.
Okay. And as a new system, like a new build, is there already a set template that you would give us to start with to work from? Or would we be going field by field and having to figure out, okay, we want this field and not that field?
No, we give you a template. We call it a form. We give you forms for trauma to start with. Where there's the long form and then a shorter form. The shorter form being if you have facilities who are not like level 1 or 2, or if they don't do TQIP, or they're maybe considered a non-trauma facility where they track your trauma for the state or whomever, but they really don't see many trauma cases. They'll put in their couple cases that they do every year, and they'll use a shorter form. But we do provide you forms out of the box.
Okay.
And then you go through and you can say, hey, and obviously we don't want you to change any NTDB questions, the questions that you have to report for them, but other things you can go ahead and change. Let me go to a tab that's the demographics is kind of generic. And then most of that you do have to report for NTDB. But you can come in and you can say, you know what, I'm going to inactivate this option because we don't use that, or we want to default an option. So if I go to Glasgow Coma score, I can actually bring up that because I have administrative rights, and I could come in here and I can go to the elements. Elements are the individual answers, and I can put them in different order. I can say what's active or not. And so I come into here and I can say, I want to make this active. I want to turn this off, or I want to order these differently. So you would determine that, but those are sent out by the system. Other questions?
So when there's an update to the data dictionary that we utilize, would those changes be coming from you, or would those changes be coming from us? I mean, making the change in the system itself.
You would make the changes in the system. When we, obviously, NTDB questions, we treat a little bit differently. So like NTDB just finalized 2025. So there's a couple of changes this year for the gender. So what we do is for all the forms out there, we define like their trauma or trauma core. Trauma core means it's usually an abbreviated trauma form. But for example, this year they have some gender identity. There's a gender identity question, and there's if they took gender hormone medications, I think it is. Anyway, for those, we say, make this one active on any trauma form as of 1/1/25. So we can, when we send out that update for the NTDB questions, we'll make it active on that particular date. And so any incidents that come in after that date that have their admission date or arrival date after 1/1/25, they will see the new questions that NTDB has. If there is a question that NTDB says, hey, we're going to retire this question, or we're not going to ask this question this year, what we'll do is we'll say, we're going to retire this question as of the end of 12/31/2024. So any admissions that come in after that date won't see it. Now, if you decide, we still want to track that question, we would leave it. You can go in and say, just keep it active. Okay. And we tell you that in our release notes. And typically the month of December is a month where we go through all the NTDB changes and tell you what to expect in that, for those particular questions that have changed. Other questions, like you might come to us and say, or for example, the state of Ohio has particular questions that maybe no other state has. And I don't recall what questions you have as a state, but if you had questions for the state of Ohio that no other state has, we're going to add them to the release. They'll go out as what we call inactive. And then you would go in and activate those, put them on which tab you want them on the form and such. Or if you came to us and said, hey, we need this field because we want to import it or export it to someplace, we would create that field and then you would have to activate it. So there is work that you will do as part of the form and updating it. There's other questions that I have on the form or that we have in our data dictionary that we don't put on all our forms, and you can activate those. During training, people will typically ask the trainer, hey, what about this question? Can I put this out there? And they're going to go through how you modify that form and how you can add questions that aren't currently displaying on your forms. But the NTDB ones, we do try and activate those all the time when we send them out to be date driven.
Okay. Thank you.
Answer the question okay?
Yes. Yes.
Okay.
Thank you.
Just jump down to outcome and talk about outcome for a little bit before we go into report writer. For our outcomes, again, you can send over ADT information, so you can get the discharge information sent over. It calculates your length of stay. If they were on a ventilator, it also calculates the ventilator days for you. If you want to track your total costs, there are fields over here where you can track, what was billed, the costs and such, reimbursed charges. Some people use those fields, some people don't. It's great for research when you're looking at how are you being cost effective. Your discharge summary. If you have a discharge summary, people will put in here like 2 pages of a discharge summary. But that's the outcomes. We do send, if you are bringing in an EMS EPCR from another ImageTrend, we will send back those outcomes to that EMS agency. And they really like working with the hospitals for that, because that's how they learn and grow and improve their care. The other thing is we have this concept of a referring hospital. If on your system you have a smaller hospital that refers or sends that patient on to a larger hospital, they start the case in the referring hospital and they say, oh, I'm discharging this person over here to a level 1 hospital. When that level 1 hospital, if they're on the ImageTrend system, we will send this information along with when that record gets sent to the level 1 hospital. So you don't have to enter all this for the referring facility. It's going to come over already pre-populated when you bring that person in. I'm going to jump over here into report writer. And Report Writer is a pretty powerful tool. We have different data sets in here, but for example, we talked about being able to pull a report on those user-defined questions. And I brought up this question on color of socks, only because it's very obvious this is a user-defined question. And so I can come in here. Now I just ran this so I could just see this overall. I could have run this and said, by counts of brown or white, whatever. If I wanted to actually drill down into this incident, I can click on this incident, and it's actually going to open that incident within the application so I can go in and do some research. Okay, so that's how I can quickly get over to that incident. That's true of any of the reports. If you want to quickly get to an incident, many times your complications and PI nurses, they really like that, so they can quickly jump over to the incident. They don't have to go search for that incident. Another type of report here is looking at, this is looking at the ISS scores over month, and it does a tabular count. But if I wanted to see, okay, in December, we had 78 ISS scores ranging from 0 to 9. What I can do with this data then is I could export this to a CSV, and on there it's going to give me some detailed information in that CSV. So if I wanted to do some research that way, I could. Now I could have wrote the report just so I can just look at incidents and just say, here's the incident number, MRN number, and here's their ISS score. But in this particular case, I just want to look at, okay, boy, we had 25, score of 25 plus for ISS in December. I may want to go and look at them and do some digging around on those particular ones. For the count of incidents by PI audit, another way I can just do some counts. It looks across the years. I can look at all the various PI audits out here. I can drill down again into one of these. So in Report Writer, you can run a report, set up a report, and run it every day. Then it'll refresh every day. And if every day you want that report on your trauma program managers so they can see it, you can email that report, you can run that report so it refreshes every day, once a week, once a month, whatever you want to do. You can export it as a PDF, you can export it as a CSV. You can even export things as a heat map. I'll just share an interesting research project at a hospital. They were having a lot of serious falls happening, and patients were coming in with these falls, and what they did is they went in and ran a report, and they found out that these falls primarily came from 2 long-term care facilities in their area using the heat map. They looked at falls and where was the address of the incident, and they used that heat map to find out it was 2 long-term care. They then could partner with those long-term care to do some fall prevention. I think it's a great ability for healthcare to do that. So that's just one of the ways that you can use a heat map. Here's just another example. Boy, I look at this and I'm like, there was, for the ISS score 25, which is pretty serious, we had 86 cases where we didn't activate the trauma team. That's pretty serious. I want to do some research on them so I could export this to a CSV and go in and do some digging around. I'm going to just show you how you can create a report. My background is nursing. I am not a technical person. I often have to tell the engineers to dumb it down for me because I just, some of their concepts they talk about, I'm like, huh? What are you talking about? So I'm just going to show you how you can write a report. We do, as part of our training, we do report writer training. We typically have you get data in the system first, and then we do the report writer training, because it's kind of, it doesn't do you much good to do report writer training if you have no data in there. I'm just going to set up just a short report here just for the sake of time. And I can say, okay, I want to do a count, and we have some of these calculations already preset up, so I can do a count of incidents. And I'm going to do my facility name. And we'll just do a very simple one. And then I can add some filters. And I'm going to say, I only want to look at information with an arrival date that is between, and I can say 01/01/2024, and we'll just do through 7/31/2024. Again, what a filter does is it looks at all your data, but the filter says just focus on this segment of that data. There are ways to filter that information down. If I just wanted to see everything across everything that I have recorded in the system, you could do that. But in this instance, what it does is just filters that data, helps to focus you. So I add that as a filter, and then I can generate my report. I showed before how for the reports, you can use different visual tools, whether you want to do pie chart, a bar graph. You can use the round circle to show like kind of a clock. But here you can see the count of facilities. ImageTrend Hospital this year has 1,000 incidents that came in. And so that's a way for you. And then I could actually take this and drill down into it. You can, when we release a report writer, when you get the system, we include over 180 reports. You will see over here in here we have some predefined reports already set up for you for when you have the audits done. And but you start out with 180 reports. You can take a report and modify it. It's a lot easier to take a report and modify it than starting off from scratch, but you can start off from scratch. I just showed you if I just want to do a very simple count of incidents, I can get that. But you can take a report and modify it. Any of those reports I showed you, we could modify. Like, for example, if you really just wanted to drill down into an ISS score 25 and just get a whole list of patients that way, you could. So you can take the existing reports, you can modify them, you can do a CSV export, a PDF export, that map export. You can set them up to run every day. You can set them up to email so that somebody has them every morning when they come in. And you give people access to Report Writer, who you want to have access to. Now, if you only have access to one hospital, when you come into Report Writer, you can't write a report looking at all the other hospitals. It'll only give you information about your hospital. But if you are a system administrator, you can run reports across all the facilities. You can do it by region. You can do it by individual facilities. So that's the power of report writing, is you can, depending upon your content rights, you can access a lot more information. Our report writer is a very powerful tool. The other thing is, if you want to use Tableau or Python or Power Builder or any one of those tools, this data gets what we call data mart. We send the data to you can create an external data mart, and those records get updated, sent over to the external data mart, and then you can use your personal Tableau, Power Builder, whatever, and run reports that way. That allows you to combine data from the database, patient registry database, along with another database that you might have. I could keep talking for hours, but I'm going to stop and say, what questions do you have?
As far as the facilities, when you create, because a lot of our trauma centers have non-trauma centers that we collect data for, and then that gets submitted up to the regions and then the state. Are those individual facilities, is that a separate fee per facility? Is it included in the overall package? And is there a limit on the number of facilities that you can add?
I'll let Patrick go ahead and answer that question.
That's a really good question. So the big thing that we take into account is just going to be the volume of trauma incidents that you would be putting into the system. Now, if you had hospitals that you need to add in to do a direct entry, or 6 months down the road you want to edit the hospitals that are in the system every day, you can do that at will. There wouldn't be an extra cost for that. We treat it as an all-inclusive type of a model.
Okay, so like in the preliminary phases, we're getting estimates of how much volume. Is that what's contributing to cost, is the volume of trauma records that are being put into the system?
Yep.
Okay.
And the same thing goes with individual users. We don't charge based off of how many people that you have in the system as well. So if you have new registrars that are coming on board, you can easily add them ad hoc without having to come in and say, hey, we have to up our user count or our license count. We don't operate that way.
Okay. What's the capability as far as data migration from previous records from an old registry? Is there a certain number, amount? Are we even able to upload old records into the new system?
Do you want to grab that one, Jane?
Yes. So we do have the capability to bring in data. You will have to contact unless you're planning to extract the data from your own database. But what you would do is you would get an XML or a CSV, and then you would provide that to us. And what we would have to do is we'd have to do some mapping with you to figure out, okay, gender over in your old system, they stored it as 1, 2, 3. We're storing it as M, F, and B. And so you'll have to help us map that. We don't know your old system, so you're going to have to know how that data is getting extracted from your old system, and then we would import it. You can import your NTDB or ITDX files. I don't know, does Ohio use, is there information based on NTDB or ITDX format?
IDTX.
Okay, so you can import an ITDX format file, and there's no charge to that. But in order, if you're going to bring in other additional data like demographics and stuff, then we would have to, there is a data legacy migration charge to that. The thing when you do import ITDX and NTDB, you don't get any of the demographics, the patient name or MRN numbers with them. But we can bring over legacy data.
Okay.
Other questions?
Just to confirm, so just for some estimations, we're looking at 25 total hospitals, about 15 of those being freestanding. And then as far as the volume is around the 13,000 trauma cases per year. Is that pretty average?
The 13 was what we had this past year as a region. The year before we had 12. So it kind of just, yeah, I mean, in increments between, I'd probably say, the 10 to 15.
And the way that our pricing is built too, we have a buffer on the lower and higher side of whichever volume that we go as kind of the average. So if you did have a year where you added another 500 or 1,000 trauma cases, it's you have a cushion to go up or down too. So overall, we're pretty easy to work with in that case, unless you're doubling the size of your overall volume. We'll probably have some talks well in advance of any changes, but we do give you that window to kind of grow and reduce calls year over year. As far as oh, sorry, Alex, did you have another question?
Oh, no, no, not yet.
Gotcha. I was just gonna mention we're we're happy to set up other calls too if there are things that pop up afterwards today. As far as kind of your guys' search process, do you know if this would have to be submitted as like a formal request for proposal, or do you have to, I guess, what does your purchasing process look like as far as hoops that you got to jump through?
I will allow the hospitals to answer that question because I'm not positive.
So I would say we have kind of two different pathways right now. So we have all of the individual hospitals that participate regionally, that we are all looking for our own individual registries to go into. And so then there would be a process for that, for the individual registries per institution. And then, of course, we have the regional side because we submit all of our data to the region, and then the region submits to the state and so on.
So there would be another repository to receive the data at the regional level from all of the individual hospitals. So that would be two different processes. And so it would really be dependent um, on each hospital system, kind of what that process looks like. Um, I don't know if you've really had a solid conversation on if we would do something collectively or not. So there could be um, some differences there. And I guess that kind of also leads to a question as well. If we're talking about a regional registry and we have other individual facilities that aren't, like, say, the region went on ImageTrend, and then we'll say UC Health went with ESO, for example. How is there any barriers as far as migrating data from one system to the other um, on the export side?
Oh, there's definitely some advantages if the individual hospital and the region were to both use ImageTrend. We do this in a good amount of states where we have the state system as the repository, and hospitals can go out and do whatever they want. There is some automation to export data from an ImageTrend to ImageTrend system. But as far as if there were a scenario where, like UC Children's, for example, if they're using ESO for their trauma direct entry, and the region has ImageTrend for kind of the data collection piece, we would work to get those files imported into ImageTrend. That's fairly common for our state systems where not all hospitals use ImageTrend for their direct report entry.
Okay. So just as back to the potential barriers, I mean, of course, I think the biggest elephant that's always in the room is cost. That's always a big concern from an administrative side, especially knowing that the databases that a lot of us are coming from were kind of on the cheaper end of pricing, and we got what we paid for. We'll just put it out there. But the challenge is definitely cost and trying to make sure we have fair pricing that because a lot of our systems, especially our level 3 centers, don't have big budgets. So that's always going to be a challenge. um, and I think it's really just making sure that it's something that's manageable for the individual trauma programs and for the systems. Um, and then as far as just the actual product, making sure that it has all of the technical capabilities and the safeguards, the firewalls, and all of the tech things that I don't know all the terms for. Because of course, data breaching is always a big topic of concern. And then cloud-based environments versus servers and all of that. And so I know that's something that in conversations that I've had, once we get to that level of talking to the IT teams, making sure that all of those things are in place as well.
Yeah, absolutely. And we've got no shortage of documentation on uh, SOC reports and all of the stuff that IT and security teams need to take a peek at. So once we get to that point too, happy to share all the info that we've got. So hopefully it gives them some peace of mind.
I mean, on the costing, I mean, I don't need necessarily details, but is there anything that's not kind of wrapped up in that lump sum price that would be like different packages? So like when you're talking about the information exchange from EMS entities that can kind of get exported into the system, is that a separate package? Is there a separate package for like the automatic export from Epic, the PI modules? You know, some registries have different packages. Is that a similar thing, or is it kind of a all in one?
Yeah, we try to package everything together in one solution for you to make just everything clean. The only piece that really is more of an ad hoc is, well, I guess there's two things. Training can always be ad hoc. We typically say, here's a recommended amount of hours that we would suggest to get you guys onboarded after you're going live and getting everyone familiar with the system. But those hours can be purchased really anytime if you have new people coming in and just want to get them quick catch up on training, we can do that. But really the integration to the EHRs for each facility, that one we do treat as a individual purchase, mainly because each hospital, it's not uncommon for them to have different versions of Epic or Cerner or Meditech, whatever it might be. So that would really be the only variable question mark on the pricing piece, but everything else we do treat as a package deal.
Okay, thank you.
Course. And I guess too the kind of the question mark for right now is on the data migration piece. What usually helps us out if you do have an idea of how far back you want to import data, like how many years and roughly how many records we might be looking at. If you have like a sample dictionary of what you're using to collect now, that would be helpful just so we can take a peek at what additional fields we would need to map. But otherwise, everything else, yeah, it would just be under one line item on the pricing.
I did have a question. I think I read someplace where you export to the state of Ohio in a CSV format. Is that correct?
It's not a CSV format. It is actually, or is it a
XML?
CV? It's an XML.
Okay, all right. Okay. Yeah, if you have your data dictionary, that would be helpful for us to take a look at.
Okay. Yeah, the files come into us as a repository as a TXT file, and then we export them up to the state as an XML.
Yeah. All right.
Because they're on a different system than us.
Okay. Yeah, we would,
Yeah.
we're, that's something we're very used to, is creating exports that go to a state, or where you have, if you're a regional and you have some hospital that's not on the same system, where we do an import from that hospital.
Okay.
Well, awesome. We're coming up right on time. Michelle, I sent you and you got the reference for Peggy. Give her a
Yes.
shout and she'll have some good intel for you. If you want some additional individuals to contact, let us know. We're in process of getting, is it Alaska right now, Jane, up and implemented or close to live? I can blank
They
it
are
on.
actually live. We're bringing over their legacy data right now.
Cool. Yeah, so depending on kind of what topics you want to get more info on, we've got some more recent users that are going through all that stuff right now, and then Peggy's been live with us for years and years and years, so she'll have a lot of good experience to share there too. But would it be fair to say give you maybe a week or week and a half to before we touch base again, or how much time do you think you'll need before we kind of chat about what we do next?
Actually, if you could give me probably about 2 weeks, just because I'm taking off the rest of the week to send my daughter to college. So I won't be available for the next few days.
Blame you.
Yeah. So, yeah, give me, I also want to check in because we do have a GPO sort of kind of, situation with some of our facilities here, when it came with e-trauma base. And then the trauma centers themselves kind of, they were on their own as well, when it came to, actually purchasing their own system. So again, these are conversations that we have to have. But yeah, let's check in about 2 weeks after I've kind of had an idea, from everyone else to kind of see what they think. And then Patrick, if my memory serves me correct, is ImageTrend presenting at the state trauma committee meeting, for Ohio in September?
We are.
Okay.
We've got about 45 minutes or an hour scheduled. I think it's on September 11th, actually,
Yeah.
Wednesday. So
Okay. All right. Awesome. Okay. Yeah, I can't, is there anyone have any other questions at this particular moment? Hearing none, see none. Okay. I appreciate everyone being on here today. I don't want to take up any more of your time. If anything pops up along the way the next couple of weeks and you've got questions, let me know, but I will be sending out a recording of this today to everyone. So I appreciate all your time.
Yeah, likewise for us. Hope everyone has a great rest of their day and great rest of your week.
All right. Thanks, Patrick.
Thank
Really
you.
appreciate it.
Thank you.
Thanks,
Thanks,
Jane.
Jane. Bye.
Thanks.